So in this session, we will take MCQs of surgery. So starting with the very first MCQ, a young male, a smoker, having pain in the legs on walking hardly for 200 meters, and then he has to sit down. Previously, he could used to manage to walk to 400 steps before taking the rest, or the 400 steps before the pain comes. Now, what could be the most probable cause? So, what actually we are, the description is actually what? You look at, of course, there is young male smoker, right? These 2 points are, the answer is perfect. Yes, it is Buerger's disease. Now, what is this symptomatology which we are discussing here? Initially, he used to walk 400 steps, then there comes the pain, and person has to sit. Wonderful, wonderful. Yes. Now, what has happened? Only 200 steps, pain comes, and person has to sit. So this actually is intermittent claudication. So this is defined as intermittent claudication, when here the pain is aggravated on activity and relieved after taking rest. Right? So this is the usual presentation. There is pain which comes with activity, and once the patient takes rest, pain goes away. So this is known as intermittent claudication, and this is in a young male who is smoker. This is classically indicating towards Buerger's disease, which is also known as thromboangiitis, the typical intermittent claudication of Buerger's disease. And yes, if this continues, then there would be a time when the person will go into rest pain. It means whether he is doing activity or whether he is doing rest, he will have pain all the time, and then we need to go for surgical procedure. So what we need to do in cases of what surgery? Any idea what surgery can we do? Very good, Chiki. We need to do lumbar sympathectomy. Very good. But in a male, if you are going for lumbar sympathectomy, you have to spare which segment? Very good. You have to leave L1. Why we need to leave L1? Very good. Yes. Ninda, Raghu. Why we need to spare L1? Otherwise, there would be, yes, in a male, yes, there might be ejaculatory dysfunction. It is very important to spare L1. Don't cut L1, otherwise you'll have reproductive problems. So this is in short about Buerger's disease, which is also known as thromboangiitis obliterans. The classical presentation in initial stages is that of intermittent claudication, which can proceed to become rest pain. If there is development of gangrene, definitely we need to go for amputation as well of the affected part, right? So in short, and of course, patient has to quit smoking. Now, next question, not a feature of burn. Yes, anyone? What will not be seen in one? Yes, Shubham, you are absolutely right. There is hypoproteinemia. So there is hypoproteinemia in cases of, so the answer is D. And sepsis, shock, we can all see. And hypovolemia can affect the kidney as well. So, okay, shock in early stages and sepsis in late stages, as the protective covering of the skin is lost. So sepsis is always a possibility there. Yes, yes. Hypoproteinemia, the reduction of albumin. Good, Pratik. No, this is important. A third degree circumferential burn involving the extremities, arm and forearm region. What is the most important thing? Yes, third degree circumferential burns in the over the extremities. Yes, Honeybee, Shubham, perfectly right, perfectly right. We need to look for peripheral pulse and circulation. Yes, arc. Okay. Now, third degree burn. What is this third degree burn? What is this? Any idea? The burn is involving or is reaching up to the bone, and what happens here? The nerves are also burned out. Right? So here the nerves are also burnt out, and because of this particular thing, because the nerves are burnt out, so the burn is painless, right? So painless burn. Yes, right. Now we come to the another keyword that is given in the question, that is circumferential. What is this circumferential word? Circumferential means encircling the entire circumference of a limb, right? So encircling the entire circumference of a limb, and what could happen? Yes, yes, absolutely, you are right. So the entire limb is encircled, and what can happen here? Because of this encircling, there might be possibility of development of a constriction band, right? Yes, right, Raghu, eschar can form. So there might be, in simpler terms, there might be formation of a constriction band. It can be eschar or fibrotic tissue, whatever. So there can be a constriction band, and whenever there is a constriction band, it has a tendency to compress arteries, right? So this constriction band can compress the arteries, and this might lead to ischemia or other vascular complications. Yes, absolutely. Gangrene if not corrected well in time. So therefore, your first priority in a case of third degree circumferential burn involving upper limb, lower limb, whatever, always make sure that there is no constricting band. Secondly, check the distal pulses. If you can feel the pulses adequately, it means there is no fear for that vascular compromise. So the pulsations need to be checked regularly, right? So always and always have a watch over the distal circulation by palpating the pulses. This is very important here. And even, yes, Pratik, you are right, that will interrupt with the proper circulation. And Aninda, you are right, if you think that there is a scar tissue, better remove it, because that scar tissue has a compressive or constrictive effect over the arterial blood flow. So one has to be very vigilant whenever you see a circumferential burn in a limb. So I think this concept is clear, right? Now, next question. A patient has ulceration on his leg where he had burn around 10 years back. And yes, everyone is right. This is nothing except marginal ulcer. Now here, the word ulcer is quite confusing because this is actually a squamous cell carcinoma. Perfectly right in your answers. So marginal ulcer is actually a sort of, squamous cell carcinoma, develops after long time, particularly at the site of burn in a patient, right? So this is squamous cell carcinoma. Now, moving forward to next question, condition which is present at birth and persist throughout life. Yes, so if you look at the options, anyone? Mark it wrong later on, right? So the correct answer is port wine stain. Now here it is quite easy to remember, right? You can just remember 3 P's. Just remember 3 P's. So one of the P, of course, is present at birth. Okay. Another P is persist throughout life, and third P is, of course, condition itself. So port wine. So I think if you remember these 3 P's, you will never forget this particular concept, and you will never be wrong in your later on, right? So remember 3 P's: present at birth, persist throughout life, and the entity is port wine stain. Now this entity has to be differentiated from strawberry angioma. Now this is a classical picture of port wine stain in a newborn, and it will persist throughout life. Now this condition has to be differentiated from strawberry angioma, and you can again remember 2 things: not present at birth. It is not present at birth, it takes some time to appear, and it will not persist throughout life, right? So it is not going to remain permanently. It might resolve by the age of 7 to 8 regional thrombosis. Right? So strawberry angioma is not present at birth, and it is not going to persist lifelong. So just remember these 2 conditions: strawberry angioma and port wine stain, right? So this way you will never be wrong in your. Yes, Raghu, you are right. As the baby will grow, it will regress, and maybe after 7 to 8 years, it won't persist anymore. So please read the statement properly, and this is one question I think you will score, right? There won't be any problem. Now, not a complication of chronic lower limb edema. If there is lower limb edema, it has nothing to do with varicose veins. Now, what is varicose veins? Yes, Raghu, Ark, you are right. What is varicose veins? Actually, if you take the example of veins of the lower limb, since they have to, push the blood anti-gravity, right? So they have valves, and the blood flow is like this. So once the blood, this is going anti-gravity, right? So once the blood goes upward, it won't come back again distally because of the presence of these valves. So it is the duty of these valves to push the blood upward and to prevent its downward accumulation. But what happens in varicose veins? These valves are incompetent. So in varicose veins, these valves are incompetent, and as a result of which, what will happen? The blood, it will come back and it will pool in the lower limb veins, right? So there is pooling of the blood in the veins of the lower limb, and if you can see here in this image, you can see the tortuous dilatation of the lower limb veins which are filled with blood, right? You can see the same condition on both the side. So this is a very typical picture of varicose veins, and it has nothing to do with edema of the lower limb which has persisted for a longer duration. So lower limb edema has nothing to do with varicose veins, which is a separate entity. And yes, what are the factors which will promote varicose veins? The conditions which are predisposing. What are the predisposing conditions for varicose veins? Any idea? Very good. So any profession which demands prolonged standing. So it can be, surgeon, it can be bus conductor or teacher, anyone who is standing for, yes, absolutely right, Shubham. So anyone who is standing for long duration of hours, they are predisposed to this condition. It doesn't mean that everyone will develop the condition, but they are prone for varicose veins. So varicose veins has nothing to do with chronic lower limb edema, right? It is just these valves, they don't function properly. Now, yeah, obesity is okay. Traffic please, good. Yes, so most commonly affected is great saphenous vein. So this is great saphenous vein. And any idea what investigation would you like to do here? Any idea? Which investigation you would prefer? Wonderful, wonderful. Doppler or duplex USG. So Doppler is good. And there is one clinical test related to, yes, USG, Doppler USG, yes, duplex scan, same thing. So there is one clinical test, and that is known as duplex is fine. Brody-Trendelenburg test. Any idea what is this Brody-Trendelenburg test for varicose veins? Now, actually, what we do here, we look for competency of saphenofemoral junction. So what we check here, we are checking the competency of saphenofemoral junction. So why I am saying so? Because suppose if this is the femoral vein, suppose if this is the femoral vein, then the great saphenous vein, it goes and it drains into the femoral vein. This is great saphenous vein, and this is the femoral vein. And this, again, this drainage is also guarded by a valve. So it just makes sure that whatever the blood, venous blood has been drained to femoral vein, it does not come back into the great saphenous vein. So if we wish to check whether this valve is working perfectly or not, we can perform this Brody-Trendelenburg test. And what we actually do here, firstly, we will elevate the affected lower limb, right? And we are doing exsanguination. It means we are pushing all the blood from great saphenous vein into the femoral vein. So when we elevate the lower limb, all the blood from GSV will go into the femoral vein. And then what we will do, we will put a finger, or tourniquet also, we can use that, right? So we can put a finger at the valve. Okay. So if you want to do a manual test, we can put the thumb over here, right? And then we will lower the limb, right? Then we will lower the limb, right? And then we will remove the thumb or tourniquet, whatever you are using, and we will look at the great saphenous vein. If it fills with blood again, it means this valve is not working at all. Whatever the blood we have manually pushed into the femoral vein, it has came back again into the great saphenous vein. So this is Brody-Trendelenburg test, which actually help us in assessing the condition of the valve at the junction of great saphenous vein with femoral vein. Anyway, this is a clinical test. So varicose veins. Now, next question. A 50-year-old male complained of pain in left thigh and left calf region, and on examination, left femoral and left popliteal arteries were not palpable. So, the condition is more affecting the left side. It is more affecting the left side, and the right side is absolutely normal. Right side is normal. It means we can feel this properly. So what could be the site of blockage? So the answer is iliac artery level. Now the pulsations which are not felt, the obstruction has to be at a level above those areas. So suppose if I'm saying that femoral artery is not palpable, it means the blockage has to be a level above the femoral artery, and that is usually either it can be at the level of iliac arteries or it can be at the level of aorta. The branches, like suppose this is aorta, it divides into two common iliac arteries, right? And then they go on to divide into external, internal iliac and continuous femoral or popliteal artery. So suppose if I say the obstruction is at the level of aorta, then in that case the condition has to be it should be manifesting on both the sides, right? But in this particular case, we know that it's only the left side which is affected, the right side is normal. So it means the obstruction is involving only the left iliac artery, and the right common iliac artery is absolutely normal. So the obstruction has to be at the level of iliac artery, right? It can't be aortic, because the moment you use the word aorta, it has to be bilateral. Perfect. And since the femoral and popliteal are blocked, so the block has to be proximal to the point of palpation of the femoral and popliteal arteries, right? So the better answer is iliac artery. Great. You understood the concept. That's very good. Now, a patient underwent long duration surgery, and then he was bedridden for many days. Now the doctor elicits a positive Homan sign, and we have been given two important keywords for predisposing factors. One is, of course, long duration surgery like replacement surgeries, and second is prolonged bedridden state. So the moment you have these two words, it is quite enough to suspect DVT. But in this particular case, there is an additional confirmatory hint given, that is the positive Homan sign. They have given positive Homan sign, and therefore these 3 points are quite okay. So in positive Homan sign, forceful dorsiflexion of the foot causes very severe pain in calf muscles, right? The calf area, right? So that is Homan sign. So the moment you have this kind of clinical picture, long duration surgery, prolonged bed rest, and a positive Homan sign, the condition is classically DVT. Perfect. So let's move on to next question. CVP is increased in which type of? Now the CVP, it actually reflects the pressure changes of the right side of the heart, and if CVP is raised, we can say that there is right sided heart failure, so cardiogenic shock. So CVP for right sided heart failure, that is cardiogenic shock. Okay. So nothing much to discuss here, because it correlates more with the right side. Clear? Cardiogenic, yes. Next question. Case of chronic hepatitis now is having hematemesis since last 2 days, and this hematemesis is because of variceal bleeding, and despite giving treatment the patient dies. And what could be the reason for the death of the patient? Yes, this is hypovolemic shock, which is actually because of excess of. So this is hypovolemic. So this is hypovolemic shock, and if someone can define what do you mean by the shock, shock is defined as a state of decreased the oxygen supply to the tissue is decreased, that is shock. And especially if there is a lot of bleeding, then it goes in favor of hypovolemic or hemorrhagic shock, right? So the moment you look at the bleeding point, hypovolemic shock. Now this is again a repeat question, so I think we don't need. So 5th post-operative day, fever, pain in calf muscles and pedal edema. This is nothing except DVT. Now this is good. A female patient is having blood pressure of 90/60, pulse rate is high, 150 beats per minute. After blunt trauma abdomen, how you are going to assess this patient? Now see, we have the algorithm for blunt trauma is we have to check the vitals first, right? In cases of unstable vitals, it means low blood pressure, high heart rate, we need to go for bedside USG, right? What you call fast. No need to shift the patient from one place to another, because you never know, during that shifting process the patient might succumb. So if vitals are stable, and if you feel that yes, the patient can be shifted to the CT room, you can send the patient for CT scan. So here BP is on the lower side, heart rate is on the higher side, so it means patient is not stable enough to be sent to the CT scan room, right? So the patient is unstable, so we will prefer doing a bedside USG. Clear? Don't shift the patient because he is unstable, right? So this is the algorithm which guide us what needs to be done in a case of, while we want to evaluate a case of blunt injury abdomen. Now, a case of road traffic accident, he was brought with blunt injury abdomen and there was simultaneous head injury. GC, the Glasgow scale was 9/15 and there was no visible external bleeding. Despite giving IV fluids, patient was still hypotensive. Now, which of the following is not the cause for this hypotensive state? I think it's quite basic. Yes, everyone can mark it right, because the bleeding in the brain it cannot be severe enough to cause hypotension. But yes, the blood which is bleeding inside the, you say, thoracic cavity or within the peritoneal cavity, or if there is injury to a structure, a vascular structure like spleen, this can cause excessive bleeding, right? And all these bleedings, they are concealed. It means they won't be shown outside. So they are concealed bleeding and they can lead to hypotension or hemorrhagic shock. So one has to be very careful while dealing with cases of pneumothorax or rupture of abdominal viscera or retroperitoneal hemorrhage. And obviously, subdural hemorrhage can never bleed so much to cause hypotension or hypovolemic shock, right? So this is important here. And also, you can remember a couple of fractures. I think it's very important to mention. So one is fracture of pelvis and another is fracture shaft of femur. These are two fractures which have this tendency to cause a lot of hemorrhage, and therefore the one has to be very vigilant while evaluating these injuries, right? There is possibility of severe hemorrhage of the amount of about 1 to 1.5 liter. Yes, Raghu, you are almost right. So whenever you see this kind of picture, always keep the possibility of hypovolemic shock or hemorrhagic shock, particularly if you think that the BP is still on the lower side despite giving fluid resuscitation. So obviously, brain hemorrhage won't cause hypovolemic shock. Now the next question, there is a patient in whom there is gallstone in the cystic duct and there is dilatation of the common hepatic duct. Now what is this known as? This is Mersey syndrome. Actually, what happens in Mersey syndrome? Suppose this is the common bile duct. We have the gallbladder. Is cystic duct. Sorry. This is the cystic duct. Gallbladder, and then it joins with the common hepatic duct. Okay. Common hepatic duct, which is actually formed by the joining of two, the right and the left hepatic duct. Left hepatic, right hepatic. Sometimes what happens, there is a stone within the cystic duct, and this stone is big enough to encroach upon the lumen of the common hepatic duct, and therefore what we see that there is slight dilatation of the common hepatic, right? So this is known as Mersey syndrome. Yes, Shubham, you are absolutely right. So this is Mersey syndrome, and you can see the picture here. There is the stone within the cystic duct, and this pushes upon the common hepatic duct, resulting in dilatation of the common hepatic. This is Mersey syndrome. Hello, next question. There is a female patient who is having pain in right hypochondriac region, which goes to the back, and this is associated with vomiting, and guarding can be seen in the right hypochondrium, and there is past history of similar episode. Now, what could be the probable diagnosis? Now, in such questions, there are few words which needs to be evaluated. First is the right hypochondrium. Of course, another thing is pain which is radiating to back. Yeah, this might confuse you. Then, okay, vomiting is not specific. It might confuse you. And there is history of similar episode. Now, what is important here? Just think of a structure which is lying within the right hypochondrium. Then I think it would be more easy for you to reach up to a particular diagnosis. So here, for that, again, you have to recall that concept of the 9 quadrants of the abdomen. If we draw different lines, this one is transpyloric plane through L1, this one is transvercular through L3, L4, then these are 2 vertical mid-clavicular planes. This is also mid-clavicular. Now, based on these 4 lines, we can divide the abdomen. Yes, Shubham, your views are perfect, but let me explain it. So, based on these 4 lines, we can divide the entire abdomen into 9 segments. This one is right hypochondrium, and this one is left hypochondrium. This one is epigastrium. This one is umbilical. This one is right lumbar. This one is left lumbar. This one is right iliac fossa. This one is left iliac fossa, and this one is hypogastrium. Now, the question is discussing about the right hypochondrium. So, specifically, it is saying that right hypochondriac region. Now, you have to think of the structures which are present in the right hypochondrium, and I think all of you must agree that there's 2 structures mainly here. One is liver and another is gall bladder, right? For pancreas, we usually take the epigastric region, right? So, the moment the word is about right hypochondrium, you have to choose your answer either from liver pathology or from gallbladder pathology, right? So, despite having these confusing words like the pain which is going to the back with vomiting, still you need to go for acute colitis because of this right hypochondrium word. And yes, this is very classical presentation of acute pancreatitis, that there is severe epigastric pain and the pain is radiating to the back along with vomiting. But we cannot ignore this particular hint given in the question. So based on that, I think it's better we mark it acute. Please remember acute cholecystitis. Now, next question. With multiple episodes of hematemesis and vitals stable, it means blood pressure all normal, but spleen is enlarged. Now, mother tells that he had jaundice and he was given exchange transfusion procedure after birth in the same hospital. Now, what the most likely diagnosis? The answer, I think little difficult for all of you, but I would like to explain this. Now, if you look here, this is a classical picture of something like what we see in cases of adults, that is variceal bleeding, right? So there is variceal bleeding. You can see there is hematemesis. So there is hematemesis, that is there is vomiting of blood, right? There is splenomegaly. Clear? So these 2 points are features of variceal bleed. Okay. Now, in a child with normal vitals, it goes in favor of portal vein thrombosis. In a child, you have to make a diagnosis of portal vein thrombosis. This is for child. Now, if the same presentation is seen in adult, usually we see there is deranged vitals. So vitals are disturbed, right? Signs of hypotension, and this goes in favor of portal hypertension. Yeah, secondary to cirrhosis. To see the basic, the presentation is somewhat similar, but in different age group, the diagnosis becomes entirely different, right? So that's why I particularly kept this question. If you see a child with variceal bleeding, think of portal vein thrombosis. In an adult, you will say it is hypertension, right? So this is in a child, you have to go, this is a case of child, vital stable, features of variceal bleed, think of portal thrombosis. Please don't mix up, just make sure that what is the age group in question, and based on that you can answer the, right? Now, next question. A lady has a lump in her upper abdomen for 2 months. So this is 8 weeks, you can say, and is slightly increasing in size. He is complaining of early satiety. Okay, this is one part of the question. Now, there is a past history, and as per the past history, she is saying that she was having acute severe pain in the upper abdomen, for which she was admitted for nearly 10 days, and this episode occurred 3 months back. Now, the third part of the question is that on examination, the mass was firm, smooth surfaced, and not moving with respiration. So, what could be the diagnosis? So, firstly, we can assume that probably whatever the condition she is having now, it might have something to do with the episode for which she needed hospitalization. So, what this episode can be? Acute, severe, upper abdominal pain, right? Any idea? Yes, Raghu, you are absolutely fine. This can be a case of acute pancreatitis. Now, based on these particular words, we cannot make a clear-cut diagnosis of acute pancreatitis. We are addressing the current situation as well. There is a lump and it is of 8 weeks duration, and that is leading to early satiety. It means it is compressing over the stomach. So that what is leading to early satiety. So that is actually a pressure effect. Now, so whatever the condition she is having right now, it means it is a complication of the episode of acute pancreatitis, and in around 8 weeks, the complication of pancreatitis which might come is, yes, absolutely fine, it is pseudocyst of pancreas. Right? So this is complication is pseudocyst pancreas, and yes, it is a complication of acute pancreatitis. And why we call it pseudocyst? Because there is no true lining of this cyst. It is just simply a collection of fluid which later has a membranous lining. So it is known as pseudocyst of pancreas, and yes, it can increase with time. So if you do, we can have a CT scan and we can see a swelling in the vicinity of the pancreas. So this is pseudocyst of pancreas, which can be a complication of acute pancreatitis in adults. In children, it can be seen after abdominal injury. So in cases of children, it is not necessary that there might be a previous episode of pancreatitis. It can occur because of even a history of trauma, right? But in adults, yes, it is always a complication of acute pancreatitis. And if the size is more than 6 centimeter, or if the duration is more than 6 weeks, obviously we have to resort to the surgical management of this condition. Otherwise, it is presumed that it might resolve, but if it is, the rule of 6 says that if it is more than 6 centimeter, or if it is 6 weeks or older, then we have to go for surgical drainage, right? So treatment point, we can go for drainage, and what we prefer here is internal drainage, and this is into the stomach, right? So we can create a portal so that the content of the cyst drains into the stomach. So this is known as internal drainage. Although we can try external drainage, but internal drainage is also preferred procedure for pseudocyst of pancreas, and this is one those rare entities where we prefer internal drainage. So just remember internal drainage for pseudocyst of pancreas. Okay, so this is the explanation to this MCQ. Next MCQ: a patient has recurrent abdominal pain. Okay? So there is recurrent abdominal pain, then gallstones and jaundice. There is reticulocytosis and hyperbilirubinemia. What is the clinical diagnosis? Now, here there are few words which you need to understand first, and then I think you will never be wrong in your diagnosis. One of the clue which is given to you is gallstones, and if you you know the types of gallstones. Principally, we have two types of gallstones. One is cholesterol, and the second is pigmented. And the third one is, of course, the mixed. So, cholesterol, as the name suggests, it has something with the cholesterol, but these pigmented gallstones, it has derived its name, and because it is seen in hemolytic conditions. It is seen in hemolytic conditions, and therefore you will see that there is excess of bilirubin, is actually jaundice in this patient, right? So here we can see jaundice, and we can see hyperbilirubinemia, that what is explained on the basis of hemolysis. Now, whenever there is hemolysis, body will try to compensate for the, now hemolysis means there is RBC destruction. So it means the body will try to make up the loss by producing more of RBC, right? And these more of RBCs are actually the immature RBCs, which we call as reticulocytes. So whatever this reticulocytosis can be explained based on this particular phenomena of hemolysis, that body is trying to produce more and more RBCs, which are actually the immature forms. And I think most of you must be knowing what RBCs, reticulocytes are. They are RBC plus nucleus. Clear? And if the nucleus is gone, they become RBC, right? So this all picture is related to hemolytic episode, and out of all the options, the best option which represent hemolytic state is hereditary spherocytosis. Okay, so recurrent gallstones, abdominal pain, jaundice, reticulocytosis, raised bilirubin levels, this is all somewhat related to hemolysis. And in hereditary spherocytosis, just take few words about hereditary spherocytosis also. So here this is actually an autosomal dominant condition, right? And here what happens, the RBCs, they assume spherical shape, spherical RBCs. Normally RBCs are biconcave disc, okay? But here they become spherical, and these spherical, they lack flexibility. So as they try to pass through the sinusoids, they cannot alter their shape, and these sinusoids of spleen, and since they can't alter their shape, so they are destroyed. This is actually hemolysis, right? This is the basic pathology of hemolysis in a case of hereditary spherocytosis. And I think all of you must agree that if we want to treat this condition, we cannot do anything related to the shape of RBCs. What we can do, we can remove the source of that hemolysis, and that is nothing except the spleen. So treatment wise, what we need to do, we have to remove the spleen. This procedure is known as splenectomy, right? But whenever you are removing spleen, there is possibility of overwhelming post-splenectomy infections, which is actually very violent pneumococcal infections. So always and always give vaccination before doing splenectomy, right? So this is in short about hereditary spherocytosis. Okay, so this is how we can just summarize up the entire thing in relation to this MCQ, right? So we can move on to next question. And parasite related to development of gallbladder carcinoma, especially after consumption of raw fish. I think most of you must, yeah, yes, Clonorchis sinensis. No much discussion in this question. Now again, we have a question in which elderly male presents with painless, right, progressive jaundice of 2 months duration, okay, and there is a history of weight loss. Patient is having loss of weight, And when you palpated, you could easily see that the gallbladder was palpable, which is smooth, non-tender, and globular. Bilirubin levels are high. Now, how we can frame all these points into a single diagnosis? Now, here, see what is happening. There is jaundice, right? Increased bilirubin, and this is reflected in the serum bilirubin level, because normally it should be around 1. It is high. There is weight loss, and whenever you find this term weight loss, always think of malignancies. Right? So weight loss in an elderly person should not be ignored. It has to be related with some tumor somewhere. Now here, what point is going to help us is the finding of gallbladder. We can palpate the gallbladder, right? So we can palpate the gallbladder. It means there is no problem, there is no pathology in the gallbladder, right? Because what happens, this kind of presentation can be seen in carcinoma of gallbladder also, but this kind of presentation can be seen in carcinoma gallbladder, and we know that one of the predisposing factor for carcinoma gallbladder is gallstones, which can lead to cholecystitis. Fine, it can lead to cholecystitis, and the important thing is that because repetitive episodes of inflammation, the gallbladder is fibrotic and shortened, right? So in such a case, it will be never palpable, right? So if you are seeing a case of gallbladder carcinoma with jaundice, and if you are able to palpate the gallbladder, then obviously your provisional diagnosis is wrong. In a case of carcinoma gallbladder, you will never be able to palpate the gallbladder because of repetitive episodes of inflammation. It would have already been shrunken and it shouldn't be palpable, right? So this is what the Courvoisier's law tells us. So if you are dealing with the case of jaundice, it can be, in terms of tumors, it can be either because of carcinoma gallbladder, or it can be the periampullary carcinoma, which most of you have answered right. So this is periampullary carcinoma, that is carcinoma of head of pancreas. Now for this, you need to understand what actually the term periampullary carcinoma is. Suppose this is the second part of duodenum here, then we all know that this is the common bile duct which is coming from above, and it joins with the major pancreatic duct, right? So this is the major pancreatic duct. This is the common bile duct. And this opens at the second part of duodenum at the ampulla of Vater, right? Major duodenal papilla, you say ampulla of Vater. So there might be the possibility that tumor is somewhere in this region, and then, right, so the tumor is somewhere in this region and it is interrupting with the drainage of the bile, right? So in this case also there would be increase in bilirubin content of the body, right? So in a tumor with jaundice, you have to palpate the gallbladder, and that what will differentiate whether this jaundice with tumor is tumor of gallbladder or it is periampullary carcinoma, right? So periampullary means it is related to ampulla of Vater, and it can include carcinoma head of pancreas, or it can also include carcinoma second part of, right? So this is a very beautiful concept. And here, Courvoisier's law help us in reaching up to a provisional diagnosis, whether the given case of a tumor with jaundice is a case of periampullary carcinoma or it is because of gallbladder carcinoma. If the gallbladder can be palpated, never think of gallbladder carcinoma, because the usual pathology of cholecystitis is going to make it shrink and we cannot never palpate it, right? So this is Courvoisier's law, and if you can palpate gallbladder, straight away you can go mark the answer as periampullary carcinoma or carcinoma head of pancreas, right? So this is very important here. So this is what Courvoisier's law help us. Now, next question, investigation of choice for dysphagia. I think most of you can answer. Investigation of choice for dysphagia. I think all of you must be knowing the definition of dysphagia, that is difficult swallowing. And whenever we are taking this particular topic, we usually take 2-3 conditions only with respect to the exam. One is, of course, dysplasia cardia. Second is carcinoma esophagus. And third, at times we can take Pancreatic diabetic. These are the 3 important conditions every student should know. Now, coming back to the question, what is the investigation of choice for dysphagia? How you will evaluate a patient who is coming to you with dysphagia? Now, the word is investigation of choice. Please mind this word. It means the one which is the best amongst all. And to answer this, I think it's better you think of a case of carcinoma esophagus. And if you want to investigate this case in a better manner, I think all of you must agree that for any tumor anywhere, what is the best investigation? That is biopsy. So that is the best investigation, any tumor anywhere. Now, if you want to evaluate a case of carcinoma esophagus with biopsy, then obviously you have to do what you need to do first? Endoscopy. Very good, Shubham. So you need to do endoscopy. So that way, I'm just correlating the things so that you can understand that investigation of choice for dysphagia is endoscopy. Right? I just gave this example so that you can correlate. We can pass a tube and we can see the interior of the esophagus or gastroesophageal junction. That is very important. So this is investigation of choice. Yes, if somebody asks you initial investigation, then yes, I'll agree, you can go for barium swallow. But if you want to make a perfect diagnosis in one shot, go for endoscopy. Now, which vitamin deficiency is seen in short bowel syndrome? Now, short bowel syndrome means there is resection of portion of the intestine, and we know that terminal ileum is the point of absorption of vitamin B12. So if we do any resection, there is malabsorption of vitamin B12. Now, this is a male newborn, and he had presented with abdominal distension and no passage of fecal matter since last 48 hours. Since last 2 days, there is no passage of fecal matter. Now here the question is about the next best. It's not about the investigation of choice or the gold standard investigation. It is like, what next will you do? So yes, anyone? Yes, perfectly fine, perfectly fine. Initially we will go for barium enema, because what is the clinical diagnosis for this case? What is the clinical diagnosis for this case? Anyone? Male patient, abdominal distension, and hadn't passed fecal matter since 2 days. What you should do? What is the clinical condition actually? Very good, Raghu. This is Hirschsprung's disease, and initially we can go for barium contrast enema, right? And if they ask you about the investigation of choice, then of course it is rectal biopsy. Rectal biopsy is the investigation of choice. Clear? Now, what you will see in rectal biopsy, there will be absent rectal biopsy, we will see absent ganglion cells of the Urbach or Myenteric plexus, right? So this is the investigation of choice, but if they are asked about the initial, go for barium enema, and this is what you will see on barium enema. So we can see a ganglionic segment which is narrow, and this is proximal dilated segment, and in the aganglionic segment we can see serrations or tooth appearance, serrations like this. This is Hirschsprung disease or congenital aganglionosis. Very good. So start with barium enema, and if you want to go for the perfect investigation for diagnosis, then rectal biopsy is best, full thickness rectal biopsy. The next question, a newborn is presented with herniation of bowel and liver through the umbilicus, and this is covered by a sac or a membrane. What is this? Very good. This is omphalocele, and the condition with which omphalocele has to be differentiated is gastroschisis. Now, in omphalocele, if you see, there is a sac. So there is a sac like this, okay? And here there is an attachment of umbilical cord. This is the attachment of umbilical cord, and here you can see the intestine. All intestine or even liver can come out. So this is a sac, right? So this is omphalocele. But what you will find in a case of gastroschisis, which is almost a similar kind of entity. So here you will see that there is a sac, not a well formed sac, with herniated content, right? There is herniated content, but the umbilical cord will be by the side. Umbilical cord is something like, so this is umbilical cord. So here we can see that the umbilical cord is right on the attached to the sac, right on the top, but here the umbilical cord is lying sideways. In both the conditions there will be herniation of the bowel, but it is just the attachment of the umbilical cord which help us in differentiating the two, right? So in omphalocele we can see that the sac, and on the top of that we can see the attachment of umbilical cord. So this is omphalocele. In gastroschisis it lies to one side. Okay? So this is one thing. Then exhaustrophy of bladder, the anterior abdominal wall is absent, so the interior of the urinary bladder can be seen through the anterior abdominal wall. So that is exhaustrophy of right. So next question, a newborn with regurgitation of all feeds and coughing and cyanosis with feeding, most likely condition. So here there is regurgitation and some respiratory problems as well. What can be? Yes, is see, there is coughing, cyanosis, regurgitation, and this is nothing except tracheoesophageal fistula. Okay? So this is tracheoesophageal fistula, and what happens here? There is closure of the esophagus. The esophagus is atretic, right? So it is blocked, and it is communicating with the respiratory tract, with the trachea. So whenever child is taking any feeds, other than going into the stomach, it is going into the respiratory tract, and that what is leading to cough. So the respiratory symptoms are based on this particular pathology. And there is possibility that whatever the feeds he is taking, it might come out through the mouth. So regurgitation and coughing, answer has to be trachoesophageal. Then a lady in her 20s presents with pain, abdomen distension and vomiting, and we saw that she is having alopecia and crepitus in the abdomen. Any idea what can be the condition? Now this is a psychiatric condition, and yes, it is trichobezoar. Tricho means hair. So the psychiatric patient is plucking her hair and she is eating them. That's why she is having alopecia, and this abdominal mass is resulting in abdominal pain. So this is trichobezoar, and there is one more entity that is known as phytobezoar. The word phyto means plant or vegetable. Yes, very good. The psychiatric condition is trichotillomania. Pulling out the hairs. So this is trichobezoar. Cut, you can see the exact appearance as that of the cut. This is trichobezoar. So the next question is about a kind of malignancy which can be expected in a case of Barrett's esophagus. Right? So the normal epithelium of esophagus, yes, all of you are right. So the normal epithelium of esophagus is stratified squamous non-keratinized. So this is the normal usual epithelium. But what happens because of prolonged gastroesophageal reflux disease? There is metaplesia, and this stratified squamous non-keratinized get converted into columnar variety. So it gets converted into the columnar variety. Yes, it's squamous to columnar metaplesia, and since the tumor which will develop depends on the kind of epithelium, so here if there is any tumor, that is going to be adenocarcinoma. In a normal esophagus, it is always going to be a squamous cell. So in a case of Barrett's esophagus, we will find adenocarcinoma just because of the fact that the epithelium has changed from the stratified squamous non-keratinized to columnar variety. A 60 years old male patient presented with bleeding per rectum, and he was having second degree hemorrhoids. What should be done best? Now, the second degree hemorrhoids are the one which prolapse. These prolapses on exertion or the bearing down effects, but they reduce spontaneously. So this is second degree hemorrhoids or second degree piles. Now what we can do in this case, yes, very good, we can do banding. So what we actually do, so suppose if this is the hemorrhoid, we can put a band at the neck, and this band will reduce the amount of blood flow, and over a period of time it will shed off. So it's just we are just cutting the vascular supply to this portion. So over a period of time this will shed off. So this is known as banding and very valuable for second degree prolapse. Then the internal opening in a case of fistula in ano is starting from, any idea? So now firstly, what is this word fistula in ano? What happens here, suppose this is anal canal, this surrounding skin. So there is a fistulous communication in like this. So there is a fistulous communication which is connecting from inside of the anal canal, and it is opening on the perianal skin, right? So this is fistula in ano, and since it is connecting with the anal canal, so the patient usually have a serous discharge commonly. So there is usually a serous discharge, which is the commonest clinical presentation. Now, in a case of fistula in ano, the usual presentation or the visual site of this internal opening is at the dentate line. So it is at the dentate. Here, this is somewhere, this is the area of, right? So the internal opening is at the dentate line. No, this is not painful. Fistula in ano is not painful, right? So it is inner, on the inner side, it is connecting to the anal canal at the level of dentate line. And to have an idea about the track of this fistulous communication, we are following one rule that is known as Goodsall's rule. So suppose if the patient is lying in front of you, and suppose this is the right side of the patient, this is the left side, and you are just facing the patient. So considering the anal opening, we draw a transverse line, and as per the Goodsall's rules, if there is any fistulous opening in front of this line, the course is always straight. Okay? So the course of the fistulous tract is always straight if the fistulous opening is in front of this imaginary transverse line. Whereas the fistulous opening which are falling behind this, line, they are going to have a curved track, right? So this Goodsall's rule actually gives us an idea that what is going to be the track, what is going to be the fistulous route, whether it is going to be straight or it is going to be curved, because whenever we are doing fistulectomy, we have to remove the entire fistulous tract, otherwise the recurrence is unavoidable, right? So this Goodsall's rule actually help us in, pre-operatively in assessing the route of fistula. If it is anterior to that imaginary line across the anal opening, we can expect a straight route, and if it is behind, we can expect a curved route. This is what Goodsall's rule is all about related to fistula in. Now, if you are, now this is, look here, this is 2 o'clock position. Right? Somewhere here, this is 2 o'clock position. So again, we can have a straight fistulous track. Right? If it is somewhere around, you can say 6 o'clock position, so or 5 o'clock, then we can presume that it is going to have a curved fistulous track. So this actually Goodsall's rules help us about the the track of the fistula, because whenever we are removing that track, we have to remove it completely so as to avoid any recurrence. So this Goodsall's rule actually help us in pre-operative planning. Now coming to next question, spontaneous esophageal perforation after vomiting or retching is a feature of. Very good, very good. Now here the important word which you need to understand is perforation. The moment you find this particular word, the answer has to be Buerger syndrome, right? So perforation of esophagus, don't think of malarias, never, right? So forceful vomiting or retching is like that spasmodic contraction of the abdominal muscles as if we are trying to vomit out. So perforation, esophageal, Buerger syndrome. And what is the clinical presentation? Now suppose if this is esophagus, and if there is perforation, the entire content is going to leak into the mediastinum, and patient is going to have mediastinitis. So patient will develop chest pain. And also features of pneumomediastinum, that is air in mediastinum. There is pneumomediastinum, and I think must be remembering one Mann's crunch. So this is Buerger syndrome, and the presentation is related to mediastinum. Yes, subcutaneous emphysema can be seen. Chest pain, yes, perfect. So this is Buerger syndrome. Now, in our repeated question, elderly patient for right hemicolectomy, 4th post-operative day, fever, swelling. This is DVT. If this, yes, Haman sign, Vishal, right? Now, HIV patient with odynophagia. Now, odynophagia means painful deglutition or swallowing. Right? So there is painful deglutition, and on endoscopy we can see serpiginous ulcers, and more importantly on normal surrounding mucosa in the distal esophagus. So whenever you have this kind of presentation in which there are snake-like ulcers and the surrounding mucosa is normal, especially in a HIV patient, this goes in favor of cytomegalovirus esophagitis. Very good, very good. So this is cytomegalovirus esophagitis. So you can see the ulcer and surrounding normal mucosa. Not too much discuss in this question. Now, next question. There is acute onset abdominal pain relating to the whole of abdomen, and there is abdominal distension, there is tenderness guarding all around, pulse is high, BP is okay. Chest X-ray shows gas under bilateral domes of diaphragm. I think most of you must be knowing the answer for this. This is of course gut perforation, and better answer amongst C and D will be colonic perforation, right? So because we are getting gas under both diaphragm, right? So bilaterally we have gas under diaphragm, so it means some bigger portion of the gut has perforated, so it has leaked large amount of air, right? So colonic perforation is better than appendicular perforation. Clear? So this is a classical case. The moment you find the word gas under diaphragm, no need to mix up. And here you can see now this white line is actually the right dome of diaphragm. Okay? And then this black shadow is the gas under diaphragm, what you call pneumoperitoneum. Okay? So this, because gas creates a black shadow on X-ray. Okay? So I think no one should err in this particular question. One of the commonest question which is asked. Okay? Colonic perforation. Now, next question. A patient was on broad spectrum antibiotics for a prolonged period of time. Now he is having diarrhea. So what is the clinical condition in consideration? Any idea? Yes, it is antibiotic associated diarrhea, and this is known as pseudomembranous colitis. Pseudomembranous colitis, and the bacteria which is implicated here is Clostridium difficile. Yes, this is antibiotic associated diarrhea, and this is principally seen after antibiotics like cephalosporins or amoxicillin. So this is pseudomembranous colitis related to Clostridium difficile. Now, next question. A young patient has retching vomiting, and retroesternal burn. And appetite is reduced because of the pain during swallowing. What could be the important, or what could be the likely diagnosis over here? Now here one word is quite obvious in making the diagnosis, and this goes more in favor of GERD. Yes, the answer has to be reflux esophagitis because of GERD. So there is retroesternal burning pain. I think it's quite easy to answer. Normally the LES should be tight enough. So the LES should be tight enough to prevent any reflux of acid from the stomach into the lower part of esophagus. So it should not go beyond this point. So this LES. But if this LES doesn't work properly, there is possibility that reflux might occur in the lower part of esophagus, and long standing cases, this is the factor which leads to Barrett's esophagus. Right? So retroesternal burning pain, think of GERD. Now, which of the following is the investigation of choice for GERD? Best investigation GERD, and yes, anyone? What is the best investigation for GERD? Yes, very good, because the normally there should be no reflux of acid from stomach into esophagus. There should be no reflux. But what happens if there is continued reflux? Now this acidic thing is going to decrease the pH of esophagus. So if we can just monitor the pH of esophagus for 24 hours, yes, everyone is absolutely right. And if we find that pH has really reduced, it is an indicator that yes, that acid is coming from the stomach and it is reducing the pH of the esophagus. So 24 hours pH monitor, best for GERD. Acute onset large volume hematemesis in mild splenomegaly. The answer, I think everyone can clearly say this is a case of esophageal varices, which is secondary to the portal hypertension or cirrhosis in an adult patient, and portal vein thrombosis in a child, right till table. Please remember, we have already discussed, and this is how the varices looks like. You can see the dilated tortuous veins, all varices. An old man presenting to the emergency after prolonged vomiting, and there is hematemesis following alcohol ingestion. What could be the diagnosis? Yes, perfect. So this is Mallory-Weiss syndrome, and here the classical presentation is hematemesis, prolonged vomiting after alcohol ingestion. And in Mallory-Weiss syndrome, you have to remember few terms. Number one, there is partial linear tear, right? Involving which part? Yes, acute gastroesophageal part or cardia end of stomach, right? And also this leads to hematemesis, very important, hematemesis. Okay, so this is Mallory-Weiss syndrome, and if we discuss another points which are Buerger syndrome, we discuss that there is complete perforation. Right? So here we have complete perforation. This is involving the lower end of esophagus proper, and patient comes to us with signs of mediastinitis. That test. So these are the few points which should be taken under consideration. Okay, so we can proceed further. Now, there is an adult patient who is having occasional dysphagia for solids, regurgitation, and foul smelling breath. Now, what can be the diagnosis here? Now, here, this is occasional dysphagia. It means sometimes dysphagia is present, sometimes the patient is perfectly fine. There is regurgitation, means whatever he has eaten 2 to 3 days back, it comes to the mouth again and again. And there is foul smelling breath. This is known as halitosis. Whenever you have this kind of, yes, perfect. Whenever you have this kind of presentation, the answer has to be Jenker's diverticulum. And here what happens, whenever the food accumulates within this pouch, right, it can compress upon the esophagus, and this results in actually dysphagia occasional. The food can come back into the mouth, so that is regurgitation, and if the food stays here for long, it will produce bad smell, that is halitosis. So all the 3 points are perfectly explained with this condition, that is Jenker's diverticulum. And yes, this is Killian's dehiscence. Next question. Not a feature of ecclesia cardia. What you will not see in ecclesia? Yes, this is corkscrew esophagus, which is actually entity related to diffuse esophageal pus. This is diffuse esophageal pus. Please remember, like we can see bad smell, occasionally regurgitation is there, and dysphagia more for liquids. Now, in early stages of ecclesia cardia, I think everyone knows the pathology of ecclesia cardia. There is dysfunction or increased pressure in lower esophageal sphincter, increased pressure DS, so it fails to relax when the food comes. But the solid food, by virtue of its weight, can dilate LES initially. Patient has no dysphagia for solid food, but liquids can't. So he has dysphagia for more for liquids initially, but later on it is equal for both solid liquids, right? That is one classical presentation in early stages of ecclesia cardia. Yes, solid can pass. Okay, now next question. Elderly patient with gradually increasing dysphagia for 3 months with significant loss of weight. The moment you find this word, significant loss of weight, my dear students, always remember one term, that there can be a possible tumor, right? So this cannot be ignored. This is actually tumor cachexia, and this is gradually increasing. It means there is, suppose if this is esophagus, initially the tumor might be this much size, right? And later on it will increase to this size. So the dysphagia is also going to increase. So gradually increasing dysphagia means the size of the swelling is gradually increasing and it is encroaching with the lumen of the esophagus, right? So loss of weight, gradually increasing dysphagia, straightforward, you can go to mark your answer as carcinoma esophagus. Yes, Raghu, you are absolutely right. Upper 2/3 you can mark squamous, lower 1/3 most commonly is adenocarcinoma because of the possibility of adenocarcinoma, right? So here you can see in the image, you can see a tumor which is encroaching within the lumen of the esophagus. Now, next question. History of weight loss and dysphagia, and he can take liquid only. He is a smoker. Now, what diagnosis you can think of? Again, you cannot ignore the term weight loss, and here the liquids, they can just slip by the side of the tumorous mass. Very good, Raghu, it's a tumor, yes. So, and smoking can be a predisposing condition here, so the answer has to be carcinoma esophagus. So weight loss, dysphagia, the solid particles they stuck, but liquid they can just make their way through the swelling. Now here what I want to show you in the barium fellow, that if you look at the picture, you can see that this is the normal lumen, right? So you can see the entire lumen has been filled by the contrast dye, but as you come down, you will see that there is a filling defect, right? So you can see that there is a filling defect. Now normally when we are giving dye, it should fill the entire length of the lumen, right? So it should occupy the entire length of the lumen. But if there is any growth in which is encroaching into the lumen, the dye is not going to fill that area, so there won't be any shadow, and this is known as filling defect. So this is known as filling defect. So if you find this particular term, filling defect, think of a mass which is projecting within the lumen, and yes, of course, the mass can be tumor as well, right? So filling defect, just look at this filling defect like this. The filling defect is some mass. Which of the following is not a risk factor for carcinoma esophagus? Yes, rat tail appearance, you can write. Very good. You can write that rat tail appearance. Carcinoma, you can remember this word. Okay, not a risk factor for, yes, anyone? Mallory-Weiss tear, what is the site of injury? Yes, the answer is gastroesophageal junction, or if there is cardia end of esophagus, whatever is given, you can just mark it. Cardia end of, right. Now next question, 4 weeks old, non-bilious vomiting, abdominal distension, and because of repetitive vomiting there is weakness or weight loss. What can be the diagnosis here? Yes, obviously this is hypertrophic pyloric stenosis. In older time it was known as congenital, but nowadays we don't use terminology. It is known as infantile, because you see the presentation is around 4 weeks. A congenital condition should have been presented at the time of birth. It is taking 1 month time. So the better term is infantile hypertrophic pyloric. Yeah, perfect. Non-bilious means the obstruction is before opening of PBD, bile duct. You know that here the obstruction is in pylorus. Clear? So this is IHES. Next question. A patient has a history of upper abdominal pain, was periodic, and it occurs at early morning. Now he is having projectile vomiting, which is non-bilious and contains undigested food particles. Patient appears dehydrated because of repetitive vomiting. So what kind of clinical picture is this? Yes, this is gastric outlet obstruction. So the person was a case of peptic ulcer disease, and now he had gone into a state of gastric outlet obstruction. And since the vomiting is non-bilious, we can say that the obstruction has occurred before the opening of common bile duct. Right? So this is peptic ulcer disease getting into gastric outlet obstruction. And this early morning pain, it means that the pain is coming on empty stomach, and this is quite obvious for which type of ulcer? Duodenal. And this kind of pain is relieved by food. So every time the patient is having gastric pain, he will eat some food. patient becomes fat, right? Obese because of too much of eating just to get that pain relieved. This is duodenal ulcer of. Now, elderly patient with projectile vomiting, weight loss, what abnormality can you expect? There would be hypokalemia, yes. There would be hypochloremia. There would be metabolic alkalosis, and this is with hypokalemia. So everything will be lost, and there would be metabolic alkalosis, which can be compensated by paradoxical aciduria. So I think it's enough for the day. Thanks to all of you for just